Hi, I'm Tom Evans. I'm the president of the Iowa Healthcare Collaborative, and I'm representing the Compass PTN. IHC is the contracting entity, but Compass is how we're actually bringing this multi-state initiative together to work with clinical practices through the TCPI project to prepare for a new world. I think everybody knows that we're going from volume to value, and with regard to our reimbursement and with the macro legislation, this is not something we're turning back from. If you haven't yet listened to it, we have webcasts on both the TCPI initiative and the macro legislation, so you can go into more detail on that. What I wanted to address today is kind of the concept, is this really happening? We've entered an era where, I think everybody knows that the country is on an unsustainable course with regard to our economy. We're borrowing money from our future generations, and frankly, we've got to do something different. It requires a different world. It requires a different way of doing what we've done. And it's interesting, I work with hospitals and physicians on a daily basis, and I've been doing this for 10 years, and every bit of our DNA is in a volume-based world. We're out bringing resources to our communities, but based on how many widgets we do it with. And we've never really had a good way of focusing on how many of those widgets are effective. The only way we're going to be able to survive within healthcare, we've got to figure out how we do better, how we are more effective with the care that we do, and that's why we're moving from this volume-based to a value-based methodology. And it's going to be hard. It's going to require radical redesign of the healthcare system. More importantly, because most of this audience is to clinical practices and to my physician colleagues, this is going to require a radical redesign of our clinical practice. How do we do what we do? All of us got into medicine because we wanted to do good medicine, and frankly, anybody who's listening to this probably could have made more money outside of medicine. But we've got to figure out how we do this. This is an interesting time also for us, is that there's never been a time where the provider community has been asked to do so much with regard to transforming the way care is delivered. So I want to just talk about that briefly, and I'm gonna rely heavily on the words of a friend of mine who gave a presentation about 3 months ago. Dr. Don Berwick was talking to he gave a presentation to CMS, and he was talking about radical redesign of healthcare. And what are the elements of radical redesign of healthcare? And this is I know this is kind of a highfalutin talk, but I think when we think about why we're doing what we're doing, it's important for us to realize this and to remember this is beginning with the end in mind. This is what the value-based reimbursement methodology is about. This is why this is happening. And my personal opinion is that the provider community is the very best ones to be leading this transformation. These are the 10 elements of radical redesign that Don Berwick introduced, and I think it's important to think about as we think about our practice and how we deliver care. It's important for us to be thinking about these different components as we do this, as we redesign how our care is, as we move toward value-based reimbursement. So the first, number one, is the change in the balance in power, or co-production. It's interesting, we live in a very silo-based world currently. As a physician, we go generate patients. The patients come in and we write orders and we tell them to do stuff, and if they need to go someplace else, we give them a referral, but we're basically the deal. And we have the hospitals and the doctors and the pharmacists and the long-term care, and everybody is kind of their own deal. And the fact is, it's not efficient. It's fraught with waste. It's fraught with duplication. So for us to actually do, and it is focused on the provider community. It is a provider-based system. What are we willing to sell people versus what does the patient need? So number one here is that we need to change the balance of power. It needs to be about co-production. We need to be thinking about not just what are we willing to sell people, but how do we build a more effective product. And the way I look at this, changing the balance of power is taking the physician and the hospital and the long-term care and the community-based strategies. We need to be thinking about what we can do together How can we eliminate the waste and duplication? How can we do this better? Most important, we need to bring the patients and the families into the room as well. This isn't just about what we want to sell them, but it's also about what they need. So we need to begin to develop much more sensitivity, becoming much more patient-centric as we go forward. So that's number one. Number two is standardization. And I kind of think of number one and number two as kind of two sides of this, or number two and number three, excuse me, as two sides of the same coin. Number two refers to standardization. Everyone knows we have lots of measures now in 2016 with regard to how we will do what we're doing. The problem is that some of the time, a large percentage of the time, we have multiple ways of measuring the same process, depending on what organization is asking for the data or who was ordained, what way of defining it. And we need to continue to have this effort of limiting the way that we measure things. We need to standardize things, and we need to promote this national language of how we measure what we're doing. We need to continue to promote standardization. At the same time, we need to continue to embrace customization. So we need to standardize, narrow but we also need to be thinking about, but that problem doesn't fit here. So we need to continue to think about how we do what needs to be done in a standardized fashion. So again, we need to do standardization at the same time we're focusing on customization. Number four refers to promoting well-being. We don't have a healthcare system. We have a sick care system. I think most people have heard that. We have a system that's aimed at identifying disease, screening for disease, preventing disease, counseling so that they don't get disease, but we really don't have a system that's really promoting overall well-being. And we need to move from thinking about how can we detect this so that we can fix something that's broken to how can we move more and more to not only keeping things from getting broken, but creating an environment where these things won't get broken. It moves from just coming into my office and I'm going to fix your ear infection to how do we create a community environment that is going to eliminate the need to have those things fixed. So again, promoting well-being is really important. This really sounds soft and fuzzy, but we need to promote the joy in the work. And when I work with hospitals and physicians, we don't really promote the joy in the work. Matter of fact, we're irritated that the work is changing because we all learned how to do something and our job is to do it that way, turn that crank until somebody changes the way the crank works. The fact is, this is about changing the crank right now. Healthcare is being reinvigorated and reinvented, and you can either crab about it and feel bad about the way things are changing, and my hope is that you will embrace that and bring your expertise in to make sure that what we do is correct, what we do is right. We need your expertise to build a healthcare system that's not only sustainable, but is providing the most efficient modeling for our patients going forward. And there is joy in this work. I've mentioned before that many of you probably could have made more money someplace else, but the fact of the matter is you got into this because you wanted to help people, and there's a joy in helping people. I'm going to take it a step further. There's also a joy in transforming this system so that it's sustainable for the future and for our children's generations. Number six, it means making it easier. Many of you have heard about lean and performance improvement. It's been very popular in the last 20 years to have the latest quality improvement methodology sprinkled over us, and if we just do that, the world will all be better, right? Well, I'm just going to make it real simple. We have too many steps. Whenever we do things, we have a lot of steps that are added to make sure that we're going to do something so that we're compliant, and that adds methodologies, oversight, all kinds of stuff that are added to the process. And the fact is, I remember seeing one time that the process in the hospital of giving a patient an aspirin required 17 different steps. And every one of those steps has an error margin. And remember that if there's 17 steps and everyone has a margin of error, the more steps you have, eventually when you think about it, it ends up being the more steps you have, the higher percentage of error, and you can end up with, I think one situation I've seen was that by the time you have 17 steps, it's only a 50% chance that you're even going to do it right. So what can we do to lean out our processes? What can we do to eliminate steps and speed things up? What can we do to eliminate the duplication to make things work better. Modernization. You know, I was trained in 1986. I graduated from residency, and there were a lot of really great things that we did then. And it's amazing to me how techniques have changed. How it's not just have the medicines changed, but the way we do things, the screening, the thinking. Some things are 180 degrees from where they were then. And we have to stay on top of things, and we need to implement the latest solutions. It's interesting that a lot of the time we're always implementing like IT solutions that are 5 years old with regard to thinking. And so I guess the point I would make is that we need to embrace modernization. It's so important to take the latest, most efficient thing and working to embed that into our solutions as we go forward. Remember that one of the problems with information technology is that it's not that the information technology itself is bad, but it's the processes that feed the information into the information technology is bad. We automate bad process. We make junk automatic if we don't change our processes. So we need to modernize. We also need to collaborate. And I've mentioned that kind of in the first one with regard to co-production, but collaboration has gone far bigger than just primary care and specialty care, or primary care and specialty care in the hospital. We need to break down kind of this wall between the provider community and the community. We need to be thinking about how do we embed ourselves more effectively with our partner, public health, or the Area Agency on Aging, to really deliver community services. I want to camp for a moment on the last two because they sound so weird. But assuming abundance, what do you mean by assuming abundance? Matter of fact, you keep asking me to do a bunch of stuff, and I can do it if you just give me a little bit more resources. Well, that's why the system has to be kind of broken. We do have enough, by the way. We have the most expensive healthcare system in the world. We have one of the most innovative healthcare systems in the world, but we have an incredibly inconsistent healthcare system with regard to service delivery over different populations. Do we need more money? Probably not. We need to just begin to assume that we have what we need and now get to work trying to figure out how we do this differently. You have what you need. Matter of fact, most of the time you don't look beyond what you are to see what you need. Back to that community piece, the collaboration piece really is helpful with assuming abundance and getting to work. Finally, the last one is kind of a return the money. Wait a minute, what are you saying there? When Dr. Berwick was describing these pieces, he brought in a story about when he was running for office, and he brought he put up a graph of Massachusetts, and it was the Medicaid graph of what was going on with Medicaid expenses as they were going up, but also law enforcement as it was going down, and education as it was going down, and other administrative services as it was going down. And he said, you know, this is interesting to look at, but he actually coined a term that he put to this phenomena. He called it confiscation. We have finite resources in our communities, and what's happening is that healthcare, as it continues to burgeon more and more and more and more in kind of an uncontrolled fashion, what we're having is we are having to decrease the spending that we're putting into other critical aspects of our society. Law enforcement, education, etc. So, and frankly, in a day when we have, I think everybody knows we have educational challenges in our country, but we now have ISIL and some other issues. So that's something that just concerns me, and I think we should be looking at what can we do to reinvent the healthcare system so that it's more cost effective, more overall effective, and it's more patient-centric as we go forward. So with that, I just want to close with thanking you for listening, and thank you for your courage. I think it's important to realize that we live in a time that our colleagues, frankly, haven't lived in previous generations. And I think it's important for us to, and I'm with Compass PTN, obviously, and we're happy to visit with you and bring whatever resources we can. But I think it's important for us to realize that we live in a special day. And I have often said this, that I believe that clinicians in 20 years will either laud us or damn us for the decisions we're making today. We live in a special time. I encourage you as a clinician to lead. We look forward to going with you on that journey.